Okay, we're going to go ahead and get started now. And we're going into the reproduction lab. So let me bring this up. This will open up to the right spot. It appears to. Everybody should see the slide that says AP2 Lab Reproduction. If you don't see that, let me know. And we're going to just jump right in. There we go. Okay. Start out with the male reproductive system. You'll see this again in lecture in a couple weeks. The external genitalia of the male system includes the penis and the testes contained in the scrotum. We see the urethra in the middle of the penis for delivery of sperm and semen. We can see the urinary bladder up here, and the prostate gland located right in this structure, right below the urinary bladder. So it's a fairly complicated system designed for, as far as reproduction goes, designed to deliver semen and sperm to the female. Now, the reason there has to be semen and sperm is the semen is the fluid that provides the medium for the sperm cells to swim. They have to have something to swim in, and the semen provides nutrients for the sperm to have energy to swim to find the egg if the egg is there. So, okay, cadaverous view of male reproductive structures here. You can see right here where, okay, there is the urethra, the penile urethra running through here. This is the urinary bladder right here. The prostate gland is located right about here. You can barely see it in the cross section here, but you can see very well the testes down here inside the scrotum, the scrotal sac here with the testes inside. And here we see a tube, a structure known as the Ductus Deferens, or the Vas Deferens. That is the delivery mechanism that sperm and semen will follow during ejaculation. The sperm cells are produced in the testes, and along with semen is produced at the seminal vesicle. I'll show you that here in a second. And they combine at the prostate gland and then go through the urethra, through the penis for release. Now, okay, so here we see a close-up of the scrotum and the testes. The testes are designed, or rather the scrotum is designed as a temperature regulator. Sperm cells can't survive at 98.6, so sperm cell production has to take place outside the abdominal cavity. It has to take place essentially outside the body. The scrotum provides that location. The temperature in the scrotum is about 3 or 4 degrees cooler than the rest of the body. Yes?
I have a quick question.
Sure.
And it might be skipping a little bit ahead, but
that's okay.
So I have a family member, male, who he ended up with one of his testes had cancer, so he had it removed. But my thing is couldn't it have also been in the other one?
It could.
Since they're supposed to be.
Right. However, the good news is that the testicular cancers tend to be very localized and tend not to spread. You know, if they're caught early on, they tend to be very localized in one and not the other.
Okay, because I was just thinking of how some women have mastectomies.
Oh, yes.
So I wasn't sure if that would be like, if it could have or should have maybe been the same. Because from my experience, people that I've known, when women that I've known got mastectomies, they got both removed.
Right.
But then my family member only got one of his removed, so I wasn't sure.
Right. Well, and that's a very good question. Breast cancers tend to spread before you catch them. You know, because it's very many times you don't know when they're going to metastasize and start spreading out in other cells. The first place they tend to go to anyway is the axillary lymph nodes, right in this region here or here. And from there, it can spread anywhere in the body. Now, the predisposition for breast cancer may play a lot with it, but then again, predisposition for testicular cancer too plays a role there. It tends to be a little easier to catch the testicular cancer because you're dealing with a structure that's about the size of a walnut, and it's easier to palpate a tumor and something that's self-contained. Whereas with the female breast is larger, and you're looking for something that's the size of a BB initially. You know, it's very hard. In fact, that model there has several tumors inside of it that are essentially BBs. And you know, I'll ask you in a little while to see if you can actually feel it. So it's easier to catch it in the male. Now, there's no guarantee that he won't develop testicular cancer in the other side. They are not, as you can see, they're not directly connected either. Like the breasts are not connected either. But so I think a lot of it has to do with timing. You know, that since you're dealing with something that's much smaller, and a tumor would be more noticeable, you know, if you're paying attention to stuff like that. You know, so that's probably why the other side wasn't taken out too.
Okay.
So yeah, no, and that's a very valid question. Why? Because generally, you know, I've known several people that have had a double mastectomy when they had cancer in one side. I know one person that had it preventively simply because all the other women that are in her family had breast cancer. So she had a double mastectomy prophylactically. She didn't have cancer, but she wanted to make sure she didn't get it. So, okay, good question. Now, as I said, the testes are contained inside the scrotum. The scrotum is a temperature regulator. There are muscles that allow the scrotum to descend or to rise depending on the outside temperature and the body temperature. We have a muscle here called the, where is it? It's called the cremaster. There it is, the cremaster muscle right there that will draw the testes up, draw the scrotum up, or allow the scrotum to go down depending on temperature. It is a temperature regulator. The sperm cells have enzymes in their head. The enzymes are designed to burrow their way through the protective layers around the egg. Those enzymes are temperature sensitive. Remember, enzymes are digestive proteins, you know, like lysosomes and stuff like that. Those enzymes don't function at 98.6 during development. So when the sperm are being produced, they may say, you know, once the sperm are produced, they're going to stay in the epididymis structure for at least 3 weeks, maybe longer. And so if they were inside the abdominal cavity, the enzymes that they need to break through the egg would break down. So the sperm are contained outside the abdominal cavity at a cooler temperature. Sperm cells then are functional. So that's why we have the testes inside the scrotum. Now they have their own blood supply. Something else to consider is that the immune system in the male body won't recognize the sperm cells, because when the immune system was in males was developed in the first year of life, you know, the T cells go to the thymus gland and they become immunocompetent, being able to recognize all the antigens on the surface of all of our cells, so they don't attack them. Well, males don't start producing sperm cells till they're about 12 years old, 11, 12, somewhere in there. Those sperm cells never existed in the first year of life. And so the blood supply in the testes is separate so that very few, if any, T cells can get down into the testes to attack the sperm cells. And it, because they're not recognized as part of the normal cells of the body, because they weren't there at that point. Now that isn't a problem in females because the female eggs were present at childbirth. The eggs in the ovaries, the eggs were found in the ovaries were there during development, were laid down during childbirth. At puberty, about 400,000 of them are still viable, but the antigens on the surface of the eggs have already been recognized by all the T cells in the female body. Yes?
Should we be able to label this for the lab test?
No, I'll show you what to label. Don't worry about this. So when we get to the models, I'll show you what you should be able to identify. Now, there is an opening on both sides of the abdominal wall that there's a canal called the inguinal canal that extends down from the abdominal cavity into the scrotum so that sperm cells can pass upward, and so blood supplies can go down and come back up also. And that is a weak spot in the abdominal wall because that's where a male, particularly where a hernia, a tear in the abdominal wall can occur because there is this weak location here. So now okay, so there's our testes inside the scrotal sac. Again, the scrotum is designed as a temperature regulator. If we look at the model here on the male structure, we can see there's the penis. In reproduction, it functions as a delivery mechanism. The tip of the penis is called the prepuce or the foreskin. The foreskin covers the head of the penis all the way up to the urethral opening, and there's nothing wrong with that, other than the fact that a male has to for hygiene, the male has to pull that skin back. Now, a circumcised male doesn't have that. This is the model here that we see in the models that you have out there are circumcised, where the foreskin has been removed. There's no health benefit either way, other than an uncircumcised male has to spend a little more time in cleaning because the skin comes over and it's easy to trap dust and dirt and debris in the layer of skin. Now this is the glans. The tip of the penis is called the glans. It is an area that is 10,000 more times sensitive to touch than any other part of the body. It's extremely sensitive to any kind of tactile stimulus. It is the counterpart to the clitoris in the female. It too is also about 10,000 times more sensitive to tactile stimulation. So these are two areas it is the contact, the stimulus of the glands of the clitoris that will lead to orgasm in both the male and the female. Okay. There's the scrotum with the testes inside. This structure here is called the Vas Deferens or the Ductus Deferens. This is the delivery tube that during ejaculation, that sperm will travel from the testes up and around. You can see it comes up here. It goes around the pubic symphysis right here, wraps around behind the urinary bladder, and combines with the structure known as the seminal vesicle. And the seminal vesicle provides about 60% of the semen necessary. At this point, sperm are moving simply through muscle contractions. They're being propelled from smooth muscle contractions in the vas deferens. Okay. Now this structure is called the epididymis. Once sperm cells are produced in the seminal vesicles, they're immature. They're not ready to be released, and they will move into the epididymis and remain there for about 3 weeks. Once they've been there about 21 days or so, then they're capable of ejaculation. They are capable of fertilizing an egg. No guarantees any of them will, but they are capable of doing that. Pubic symphysis right there. And now this is the urinary bladder. You'll notice that the Vas Deferens comes up and wraps around the urinary bladder. And you just get the hint back here because there's a Vas Deferens on this side and there's one on the other side, and they come together back here. There's a seminal vesicle. That's what this thing is. There we go. There's the seminal vesicle. That is a semen producer. There's one on each side. The seminal vesicle and the Vas Deferens on each side come together, so we get a large surge of semen to go along with sperm cells. There's another set on the other side because the ejaculation is going to give you about 400 million sperm altogether, the combined effect of both left and right testes. Anal sphincter. And now there is the prostate gland right there. Now, one of the advantages of having the rectum right behind the prostate gland is that for palpating the prostate, it's very easy for a healthcare provider to do a digital examination of the prostate. In other words, they stick their finger up the anus into the rectum. And since there's a very thin wall of tissue between the rectum and the prostate, the healthcare provider is capable of palpating the prostate to check for prostate cancers. So again, slow growers, not something noticeable, not something that that you could palpate on your own or detect on your own, but they call it digital because it involves a finger. So essentially, they stick their finger up your butt and they press against your prostate. They feel for any lumps that shouldn't be there. Your average physician, and there's no disrespect here to your average healthcare provider, doesn't always detect it initially. They may think they feel something, but then send a mail to the specialist simply because the urologist will palpate hundreds of these on a weekly basis, and your family doctor will probably do 2 or 3 a week. So but it's a very easy, uncomfortable procedure, but it's a very easy procedure to detect something that shouldn't be there. Now, is that the be-all, end-all detection? No, there's also a blood test to test what's called PSA for, and we'll get into this in lecture, prostate-specific antigen. Is that the be-all, end-all? No. Both of those can indicate something might be there. The only way to tell for certain is to do a biopsy of the prostate if there's a suspicion that there's a cancer. Much like if your patient has a suspicious lump in their breast, and well, it might be cancerous, it might not be cancerous. The only way to tell for certain is through a tissue sample. Anyway, there's the anus right there. Now, okay, close up on all this. There is the Vas Deferens. There's one on each side of the urinary bladder. This is the urinary bladder right here. Right there, there's the urinary bladder. And this Vas Deferens wraps around here. This structure number 17 is one of the seminal vesicles. And the seminal vesicles and the Vas Deferens on each side come together into a duct inside the prostate gland, this brown walnut-shaped structure here. Now that's one of the ureters. The ureters have been cut here to get them out, keep them out of the way, but that's one of the ureters. Both ureters, one on either side of the urinary bladder. Seminal vesicle, prostate gland, rectum, and anus. Okay, A little closer examination of the scrotum and the head of the penis. There's the scrotum, the testes, the epididymis, the spermatic cord, which consists of the blood vessels and the cremaster muscle. There's the Vas Deferens right there. Now, if we look internally, we can see there's the glans, penis, the prepuce, the area of the foreskin, the penile urethra. Now, the urethra is long. The urethra is about 20 centimeters or so to go from the opening here to go all the way back up here to get to the urinary bladder. So it's about 20 centimeters from here to here. That the one thing that does for males is it tends to lower their instance of urinary tract infections because it gives their immune system more time to fight the infection. The urethra length in the female is very short, 4 or 5 centimeters, as opposed to 20 here. Okay. Now, the area, the structure that surrounds the urethra is called the Corpus Spongiosum. It is spongy tissue. When the male becomes sexually aroused, the arterioles that supply blood to the corpus spongiosum will dilate and more blood will flow in. And into it's like a sponge, essentially. That's why they call it spongiosum. At the same time, the veins will become compressed. And what the end result of that is that when the male becomes sexually aroused, more blood is coming into the penis than is leaving, and as it fills up the spaces, it causes an erection. Now, the corpus spongiosum tends to surround the urethra. Its purpose is to become enlarged and help achieve the erection, but it's also designed to protect the urethra and keeps the urethra from being pinched or closed. You'll notice that in that blue band right there, we have 2 paired areas of spongy tissue called the corpus cavernous. They run along the dorsal surface of the penis, and they are the primary areas that become engorged with blood and cause an erection to occur. The spongiosum has 1 layer, 1 band, and the cavernosum have 2. And I'll show you a slide here in a second on that. There's the testes, there's the epididymis, urinary bladder. There's the prostate gland right there. Prostatic urethra. During ejaculation, there is a sphincter, a ring of muscle right at the prostatic urethra that shuts off the urinary bladder, so no urine is released during an ejaculation. Because this little tube here, which looks like it doesn't go anywhere, actually extends to the outside, and that is where that's the ejaculatory duct. That's where the combination of the seminal vesicles and the Vas Deferens have come together to go into that duct. So they come into the prostate below the level of the sphincter so that no urine gets mixed with anything. And there's the ejaculatory duct right there. And then the membranous urethra is what leaves the prostate and goes on down here. And we'll see later that there is, the prostate provides about 30% to 35% of additional semen. So we're up to about 95%. And there's one more gland located back in here called the bulbourethral gland. It provides the last 5%. In fact, that is the first semen that gets released during sexual arousal in the male. It's designed to neutralize bacteria and any kind of pathogens that might be found in the urethra. Yes.
So I know that after intercourse, I'm not sure if this applies to men, which is why I'm asking, but I know that women are usually advised to use the restroom. Would
Mhm.
that be the same for men too? Because wouldn't, like, if they don't and they have leftover semen, and like, wouldn't that create a urinary tract infection just like it would in women? Or
Ger-
like it does in men?
yeah, generally not, because the semen, it has antibiotic properties of itself. It destroys any pathogens, any bacteria that would be in there. In fact, that first 5% that's primarily what it does. It destroys that, so that the males don't tend to develop UTIs like that. So part of it is the length of the urethra. Part of it is the fact that they have neutralized or destroyed anything that first 5% of semen that comes out. Not only does it lubricate the tip, but it also kills any bacteria. So that's not to say that the female may not have some sort of bacteria anyway, and it's entirely possible. But generally, males tend not to do that. The problem for a female is that because of the proximity of the opening of the uterus with the vagina and the urethra and the rectum, all in a very close area within just a few inches apart, it doesn't matter how clean is clean. It's always challenging for your female patients to keep themselves as clean as possible. Everybody who practices great hygiene, bacteria are still there, and you have a warm, dark, moist environment within an inch or two of everything else. So it's very easy for bacteria to migrate into the urethra, into the urethra, and since it's just a very short distance into the bladder, it doesn't have time for the immune system to really kick in. So it's lots of women do everything right and they still get UTIs. It's not their fault. It's just the way their body's designed. So yeah, it really is. I'll show you when you see the models here. The distances are so small, and bacteria love a dark, warm, moist environment. See, in the males, the opening to the urethra is much further away from the rectum than in the female. It's far enough apart that bacteria don't have as much of a chance. They can still get there. It's not like it's impossible. But the fact that the urethra is so long to get to the bladder, that's an advantage that the males have on that. So, okay, here is the testes and the epididymis again, scrotal sac. Now, this is what a cross section of the penis looks like. The two upper bands, the spongy tissue, are the corpus cavernosums, and they run the length of the dorsal surface, the top surface of the penis, and the spongiosum surrounds the urethra. You can see the urethra opening is right above where it says corpus spongiosum. Let me see it. Didn't have anything labeled on there. So during an erection, the spongiosum will fill up just like the cavernosums do. And the spongiosum is designed to protect that urethra, because the urethra can get bent and pinched. The whole structure, the penis can be bent. There's all sorts of studies and reports of injuries like that. But the idea is that the cavernosum then provide an erectile, they provide enough of blood coming in there and restricting blood going out to provide an erection. And in lecture, we'll talk all about the role of the erectile dysfunction drugs. Essentially what they do, and I'll just keep it real brief, is the problem in erectile dysfunction is that the veins that drain the penis don't get blocked, don't restrict the flow. What the erectile dysfunction drugs do is enable blood to continue to come in faster than it's going out and start compressing the veins. That's, you know, that's a real brief summary. We'll spend more time on that in lecture. Since it's a multi-billion-dollar industry, we need to talk about it too. So, okay, there are the testes. Sperm production starts on the inside wall of the testes up here at the edge, right along the edge. And sperm start developing here, and they start moving down through this layer of seminiferous tubule until they form what are called the immature spermatozoans, which migrate into the lumen. There we go. These are spermatozoans. They are immature. They will migrate from the lumen of the seminiferous tubule to the epididymis, and then they'll finish their maturation. The process, you know, of sperm production, we call it spermatogenesis. We form these spermatocytes. The spermatocytes come from these cells called spermatogonia. Spermatogonia are diploid cells. Everything else is haploid. The spermatogonia are diploid. And when they undergo mitosis, half of them stay there as spermatogonia, and the other half undergo meiosis. Yes.
Sorry,
That's okay.
So I'm going to backtrack just a little bit because earlier we talked about that sperm don't survive at 98.6. So my question, and I'm pretty sure we went over it a little bit in AP1, I just want to double check, but we went over that men who have or who spend a lot of time sitting down have less sperm production because their scrotum is closer to their body. Is that
Right. Right. Yeah. Anything that's going to keep the body temperature high, you know, in males is going to have an effect on sperm cells, you know, whether they're sitting down a lot, even to the point of what kind of underwear they wear. You know, if you wear tighty whities and you hold the testes and the scrotum up close to the body, something as simple as that may affect the sperm count, you know, because you may be producing 400 million sperm, but they've gotten so warm that the enzymes on the head of the sperm aren't functional anymore. So sometimes it's infertility can be treated simply by changing the type of underwear that a man wears. So, but yeah, anything that's going to keep them, keep the scrotum and the testes closer to the abdomen is going to raise the temperature, and it's going to affect sperm production. Now, how much does it affect? I don't know. Because, you know, but we are dealing with 400 million sperm, and, you know, you need to have, at least if you're producing less than 100 million viable sperm, meaning capable of reproducing, then you're going to be considered infertile. So, good question. Now, spermatogonia, they're diploid cells. They undergo mitosis. Half of them stay there to keep doing this again and again and again. The other half start migrating down through the seminiferous tubule. They become the spermatocytes. They undergo, instead of mitosis, they undergo meiosis. Only sex cells undergo meiosis. Meiosis is nuclear reduction, because we want to go from 46 chromosomes to 23 chromosomes. We want to have a haploid cells and not diploid. And so we get that, but they're immature. And it takes them about 3 weeks before they're mature enough to, I mean, they can be ejaculated, but they're not ready. So, okay, sperm cells. Typical ejaculation is about 400 million sperm. By the time you get to the egg, you're down to a few thousand. The mortality rate is extremely high, going through the vagina, cervix, and into the uterus. You deal with temperature, you deal with acidity, you deal with all the folds on the inside where they can get stuck. Sperm cells don't have a reverse gear. They only go forward. And as they go into a fold, unless they happen to, and all they do is go forward, unless they happen to bounce outward, they're going to be stuck in there. Anyway, sperm has the head has the digestive enzymes. You know, all these enzymes here are essential to penetrating the layers around the egg. The egg has two distinct layers, and the sperm have to digest away those layers to get in there. And it takes thousands of sperm to do that. Once you get to the cell membrane of the egg, one sperm and one sperm only will penetrate. But it has to work through all the two thick layers around the egg. There's the head, there's the tail, we call it the flagella. There's the acrosome, which you can see right there, is the cap on the head. That's where the enzymes are stored. We don't want those enzymes getting out ahead of time because it would damage, it would damage the testes, it would damage the scrotum, it would damage the uterus and the vagina and the uterus and the female to release those digestive enzymes. We don't want those to be released until the egg and sperm are in very close proximity to one another. So they're contained inside the acrosome. They're protected inside there from being released. It isn't until the acrosome becomes very fragile that those enzymes can come out. Okay. Now the midpiece of the sperm, so we have a head, we have an acrosome on top of the head, we have a midpiece, and we have a tail. The midpiece is packed full of mitochondria. There's lots of glucose inside the semen. That's where the sperm cells get their energy. And all the mitochondria do is power the tail so that they can swim forward. The tail whips around in a circular pattern so that it's pushed forward through the semen. And it is, its target is going to be the fallopian tubes. Now, the head of the sperm may be able to detect the presence of an egg on one side or another. Often though, that sperm cells just swim up into the uterus and they keep going until they find an opening. So, half of them may go the wrong way, or they may all follow the chemical scent of the egg. But the mortality is extremely high. Again, you're dealing with higher temperatures, you're dealing with acidity, you're dealing with folds, and as you get thousands. You went from 400 million to a few thousand by the time you get to the egg. Okay. Now this slide here is, we know it's something biological. It isn't real obvious, but this is the prostate gland. This is a healthy prostate gland. Prostate gland is secretory in nature. Its role is to produce semen. 35% of the semen that we use to get the sperm to the egg comes from the prostate gland. The seminal vesicles produce about 60%. The prostate gland does about 35%. And the bulbourethral gland does that last 5% here. And so here's the urethra going through the middle of the prostate gland. These are all secretory glands up here. And one of the things you'll notice is they're all fairly uniform in shape. They all have, they all look about the same. One thing you'll see when you see cancerous prostate cells is that they're very irregular. Some are large, some are small, some have grown over top of other ones. But a healthy prostate gland, the cells would look fair. As I said, you can see their shape is fairly consistent. The structures with the semen stored inside here all look about the same. I mean, some are bigger, some are smaller, but they all have about the same shape. So, and of course, there's the urethra. We have smooth muscle layers that control the contractions that help to force the semen and the sperm out here. Okay. And there's an alveolus where we store, semen ready to go. Okay, the secretory cells are filling that alveolus up. Okay, now this is what I was talking about earlier. On the left-hand side, oops, let me go back. Got carried away. Left-hand side, those are normal prostate gland cells. You know, we're not zoomed in so much like we were earlier. On the right-hand side is prostate cancer. You can see that the cells, the first thing you notice is that they're overgrown in each other. Cancer cells do not have contact inhibition. They grow on top of each other. Second thing you see is that there are many irregularities in the shape and the structure of these glands. You know, there is no, the one thing that's consistent is the lack of uniformity here. You look on the left side, all the cells look about the same. They look normal. They look, you know, uniform and consistent. On the right-hand side, this is characteristic of cancer cells and is a lack of consistency, a lack of uniformity, a complete randomness as the cells pile upon each other. So not being a pathologist, you can look at this and still say, cancer, lack of cancer. Cancer cells have no uniformity. They have no consistency. Healthy cells are uniform. They are consistent. They maintain the same size and shape throughout. We don't see that with cancer cells. Okay. Now, the female reproductive system, a lot more complex than the male system. It has to be. It has to do more things. It has to bring an egg to maturity every month. It has to release it. It has to find a way to get that egg into the uterine tube. And if that egg is fertilized, it has to get it down to the uterus. It has to let it implant. And then it has to provide nutrients for the baby for the next 9 months, and then deliver the baby, and then provide food for it from the breast with milk. So there's a lot more going on here in the female reproductive system. Now, the primary structure we see first is the uterus. The uterus is about the size and shape of an inverted pear. You know, so if so it's about between 2 and 3 inches long, with the fundus, the curved part at the top, narrowing down to the cervix and the vagina at the bottom. And on either side of the uterus, you have a fallopian tube or a uterine tube or an oviduct, 3 different names, that stretch out and end in these structures called the fimbriae. That's out here. You know, here's an oviduct, and these things that look like fingers are the fimbriae. The fimbriae, fimbriae means finger, and what the fimbriae do is they generate a current to draw the egg after it gets released into the uterine tube. This is what, stop sharing for a second. And okay, this is what a uterine tube with the fimbriae look like. These are the fimbriae here. When an egg is released, the egg is released into the abdominal cavity. You can see it right here. An egg, here we go. There's an egg being released in the abdominal cavity. An egg, or even better on there we go. That structure right there, the green structure, is supposed to be an egg. That egg has been released from the ovary here, and it's released into the abdominal cavity, and it has to drift and find its way into the uterine tube. Now, the uterine tube in this case is designed, the uterine tube is always designed to have these fingers that generate a current to draw the egg in, because there's no direct connection. The ovary is not connected directly to the uterus. There is the uterus is lined up right. The uterus holds the ovary in place, but there is no connection between the released egg getting into the uterine tube. So what the fimbriae does is, generates a current. the egg gets drawn there. Maybe. We don't know. You know, many females can tell you when they ovulate on a monthly basis. Sometimes they can feel some pain in the side as the ovary ruptures, lets the egg out, and others don't. But there's no guarantees after that the egg is ever going to make it into the uterine tube. So if the egg gets there, it's because the fimbriae have been moving and generate a current to draw the egg up into this uterine tube. Now, once it does that, then the uterine tube is lined with pseudostratified ciliated columnar epithelial cells, meaning there's cilia to push the egg along down here to the uterus. It takes about 7 days for that little egg to make its way to the uterus. Now, if implantation occurs, it will take place somewhere after the 21st day of the ovarian cycle, meaning there's only 7 days left before menstrual flow starts. So you got to get that egg has to get embedded fairly quickly. So what we do know is that the chances of pregnancy, it's somewhere around less than 20%. There's a less than 20% chance of pregnancy on any specific intercourse event. So not great odds. So lots of things have to work right. Many things can go wrong. So we'll talk a lot about that in the lecture. Anyway, so the fingers are called the fimbriae. The tube is called the infundibulum, same term we use in the prostate gland. I mean, in the pituitary gland. The ampulla is a widening of the fallopian tube, generally where fertilization would take place. So whether the egg is fertilized or not, it will continue to work its way down here to the uterus. Even if it's fertilized, it may not make it there. It may get stuck and stop growing, or it may continue to grow in the uterine tube. About 1 out of every 1,000 fertilized eggs start growing inside the uterine tube. That generally doesn't end too well. We see that the uterus is attached to the vagina through a structure known as the cervix right here. The cervix is a canal. It's designed to protect the opening to the uterus. Remember, this is all open to the outside. So the vagina is open to the outside. The uterus is open to the outside through the cervix. The cervix tends to block the opening to the uterus with a thick layer of mucus. So, yeah.
So I know that sometimes there's ectopic pregnancies.
Mm-hmm.
How exactly does that happen?
Well, we don't know why it does. We know what happens is that the fertilized egg decides to stick in the uterine tube and start to grow. And it can grow and survive for about 3 months before it ruptures. And this is the bleeding out. What will happen is it will rupture, and because it has caused a significant blood supply to grow around it. I mean, our bodies are perfectly capable of creating additional blood supply wherever we need it. It's called angiogenesis. So what will happen is it will implant itself in the wall of the fallopian tube. It will cause an increased blood supply to grow there, and then somewhere it'll get too big for the fallopian tube, and the tube will rupture somewhere before the end of the 3rd month, and then there'll be significant bleeding out, and that can kill the patient. In fact, bleeding out from an ectopic pregnancy is the #1 cause of death in the 1st trimester of pregnancy. So it's something that has to be treated immediately at that point, because otherwise your patient and the baby are going to die. Now, there are some cases where an ectopic pregnancy can come to term. They're very rare, but they do happen. So, because they have to be delivered through a C-section, obviously, and somewhere, they're probably taken out much earlier than the full 270 days, 9 months that they come out before that. But it is possible to come to term, to be delivered. Pretty unusual. There's great risk for the mother, because if, because it doesn't take long to bleed out if that ruptures. So, but why it happens, we don't know. We don't know why the egg gets stuck in the tube. I mean, the egg itself is it's a one-celled structure for about a day. By the time it gets to the uterus, it's about 150 cells. It's still, about the size of the pointy end of a pin. I mean, it's going to grow really fast, but it's so tiny, you can't imagine how it would get stuck, but it does. So, okay, good question. Thank you. I've got some great imagery I'll show you in lecture. So, in that vagina, cervix. Let's see. We hold the uterus in place with ligaments. The uterus is tilted over top of the urinary bladder at a 45. It's about a 45-degree angle to the vagina. So it is not like a straight line. There's a tilt to it. We'll show you here. Here you can start to see some of that. Here is the vagina right here. There's the urethra right in front. There is the urinary bladder right here. And where is my, yes, there is the uterus here. You notice that it's a 45-degree bend right there. So let's take a look. Here we go. Here we've turned it around now. Different, we flipped the perspective, but see how the urinary bladder sits right here, and the uterus is right on top of the urinary bladder. And then we have the cervix at the end of the uterus and the vagina coming down here. So it's a right angle there. Oops. Now, one of the things that makes a pregnant female very uncomfortable is as the baby continues to grow, the baby is pushing on the urinary bladder. You've got 20 pounds of baby in fluid now sitting on top of the urinary bladder, which probably makes life pretty uncomfortable for the mother. But that's, and so, a lot of, like the need to pee all the time is evident. But what we see here, there's the urinary bladder, there is the uterus right there. You can see one of the fallopian tubes and just barely see an ovary there. Here we see the vagina. You can see the opening of the cervix. There's the urethral opening there. There's the opening of the vagina there. And back here is the anus. So all in close proximity to one another. Here. At the anterior end of this area called the vestibule, we have the clitoris. This is the counterpart to the glans penis on the male. It is erectile tissue. It does become engorged with blood, and the clitoris will become erect. I mentioned in lecture today that the clitoris can actually assume the shape of a very small penis if it's being exposed to high levels of androgens in a female body. That can happen. But it does respond to sexual arousal the same way the male does, in that it becomes engorged with blood and becomes erect. The nipples on the breast have the same response too. When the female is sexually aroused, the nipples will stand up too, simply because of the increase of blood flow going in. So, okay, rectum and anus, and here we see the mons pubis. This is a layer of fat that sits on top of the pubic symphysis right here. And this is where you see the difference in pubic hair in male and female anatomy, whereas the mons pubis tends to have most of the pubic hair here as different than what you see in the male pattern of pubic hair, it tends to spread up higher than what we see in the female. So close up on the model, pubic bone, where that's, our pubic symphysis is right in the middle of this. There's our urinary bladder, the ovary, the fimbriae, the oviduct, or uterine tube, or fallopian tube. There's the outside of the uterus, the outside of the vagina, the rectum, the anal sphincter, the anus, right there. Now, if we examine this a little closer, pubic bone, bladder, ureter, ovary, fimbriae, oviduct, uterus. Even though you can't really tell a whole lot from the way this model is designed, you can at least see that the uterus is still sitting on top of the urinary bladder. Vagina, yes. Oh, I'm sorry.
No, you're fine. I wanted to ask about, because I know that some women go through IVF to be able to conceive. How exactly does that work? Because I know that some IVF procedures have to do with shots. And how exactly does that all play out to help them conceive?
Okay, what happens is that the hormones, the two hormones that affect the ovaries are follicle stimulating hormone and luteinizing hormone. We'll get into that in repro in lecture. But follicle stimulating hormone stimulates eggs. Now, conventional wisdom says that that the adult female has all the eggs she's ever going to have, about 400,000 of those, and she's only going to use about 500 over her reproductive lifetime. There is newer thinking that perhaps eggs are being made all the time. So regardless of that, whether females are making eggs or not, it doesn't matter. What hormone therapy does is helps to stimulate production of more eggs. So at one time. Generally, follicle stimulating hormone brings one egg together each month, or one egg ready to go. There's a cluster of eggs that are being stimulated, but by the time we get to the point of ovulation, there is one egg and one egg only. The other ones that were being stimulated by the FSH degenerate and go away. With hormone therapy, we get more eggs ready to ovulate at the time. Instead of just one, we get a half a dozen. And so you can harvest those eggs. You can go in into the abdominal cavity, and you can actually collect those eggs and place them in a petri dish with some sort of neutral saline, and then expose that to sperm cells. And the success rate is probably around 25%. It's about the equivalent of normal intercourse. So, and then once you don't know if it's been fertilized or not, but you assume if the eggs and sperm are all exposed to each other that somebody got fertilized. And then you can implant all those eggs into the uterus and see what happens. Sometimes nothing happens. Sometimes a lot happens. There was a case a number of years ago. Remember, if you ever heard of the Octomom? She had 8 eggs fertilized. Well, they were all implanted. They all grew to term. She had octuplets. They're all doing fine now. I saw an article about that just a few weeks ago.
I think I did too. I think they're like 13 or something.
Yeah, so they're old. They're getting older. They all survived. It's sort of the luck of the draw as to whether or not they're going to get fertilized. The reason they usually implant all the eggs is because they don't know if any of them got fertilized, or if some got fertilized, or or they all got fertilized. So you just implant them and see what happens. So, but the success rate is pretty good. Lots of people go through IVF, and for a lot of people, it works very well. And for some, it doesn't.
Well, wouldn't cases like hers be like really high risk? Because I know that like even in some triplet cases, they're considered high risk.
Oh yeah, yeah. You know, human bodies are not designed to carry 8 babies to term. The reason that dogs and cats can have large litters is because they actually have multiple uteri. So that I found it out the hard way with my Basset Hound. She'd never had any puppies, and it turned out that if you don't have your dog fixed, she'll develop a severe infection in the uterus, in the multiple uteri. You have to have them all removed, or else it'll kill her. I didn't know that, so because we'd never had her bred or anything like that, but we never gotten around to having her fixed until we had to. So it was emergency surgery. But see, a dog or a cat can carry 8 or 10 or 6 or however many in a litter because they have a uterus for each one. But humans have one uterus. So, and we're not designed, we're just not designed to carry 8 babies at a time. I mean, especially, and the artificial implantation really had nothing to do with it. There are always cases of someone popping out 8 babies. You always hear about someone who conceived and had 8 children, but that took 8 eggs being released from the ovary. That's what makes it so unusual, is to have 8 children. Either that fertilized egg had to split itself 8 times, or you had to have 8 eggs from your ovaries. So it is a high risk pregnancy. And I know she got a lot of criticism over that because of her, people said she was very selfish for doing that. She's very fortunate that they all came to term and they were also, all successful. So, but that brought her up to like 15 kids or something. Some ridiculous number. So
I can keep cheaper by the dozen too, literally.
Oh yeah. But it just so I mean, IVF works. IVF's been around for a long time now. It does usually require hormone therapy to help stimulate the eggs. You use luteinizing hormone to trigger ovulation. You want the eggs to ovulate when you're ready to collect them. So you use luteinizing hormone for that, and you capture them. The technique of capturing it is fairly straightforward. Once you get the eggs and have the sperm available, it's, the hard work is over. Then reimplanting them is pretty straightforward. But again, with every step of the way, there's no guarantees that anything will happen. You can go from complete conception on all 6 or 8 or 10 eggs you got, or nothing, and everything in between. So, but it does work. It works pretty well. So, I think I read somewhere recently that the earliest, they used to call them test tube babies, because that's, for want of a better term. But the earliest children conceived through IVF are in their 30s now, I think. So they're old enough to be having children of their own, and I think they are. So, answer your question.
I think so, yeah.
Okay, so feel free to continue asking. So, okay. Now, let's get into let's get into the inside here. There we go. Now, there is the uterus right there with the urinary bladder on top, the mons pubis over here. There's the pubic bone. There's the bladder. There's the urethra. There's the uterus. There's the cervix and the vagina. And you can see it's actually a 90-degree turn right there, because the bladder sits on top of, the uterus sits on top of the bladder, you see that there's the opening to the urethra, there's the opening to the uterus, and there is the anus right there. So again, very close proximity, making it very easy for bacteria to move around. There's the mons pubis, this fatty little bump there right over top of the pubic symphysis, mostly the area where you would see pubic hair. That little structure there, you can barely see it, is the clitoris. It will become engorged with blood when the female is sexually aroused. It will become erect. It is extremely sensitive to, this is the area that's extremely sensitive to tactile stimulation. And it is the stimulation of the clitoris that causes the female to reach orgasm through the constant touch in here. Now these structures here are called the labia, these outer fold and inner fold, called the labia major and the labia minor. The clitoris is found at the junction of the labia minor on the anterior surface, towards the front, right there. And these folds protect the area of the opening of the urethra, the clitoris, and the vagina. This area is referred to as the vestibule, and so they're protected in there. They're also heavily lubricated during sexual arousal. There are lots of mucus glands that release right into that area too. There's the labia minor is the inner fold. Then there's the vestibule. There's the rectum and the anus. Again, you notice there is no prostate gland. There is no seminal vesicles or anything like that. All we have are the uterine tubes coming off and the ovaries coming off of the uterus. So, like right there. The ovary, about the size and shape of a grape, with the fimbriae that lay over top of it. But again, there is no direct connection. There's no guarantees that the egg, if an egg comes out, it's not going to go wander off out here in the abdominal cavity and be lost. Okay. The Fimbriae Oviduct. And this is what the typical ovary looks like. You have hundreds of thousands of eggs in there, maybe growing more as we go along, because conventional wisdom said that at childbirth, the female ovary has 3 million eggs at childbirth, 1 million eggs by puberty. No, I'm sorry, 3 million eggs at conception, 1 million eggs at childbirth, and 400,000 at puberty. She's only going to use about 500 over her reproductive lifetime. The concern has always been that as the female ages, do her eggs age with her? Well, conventional wisdom has always said a 40-year-old female is going to have 40-year-old eggs. And the concern is an old egg going to be viable? Is there going to be things wrong with it? Because these eggs have been around for a long time. What we think we're seeing is evidence that in this epithelial layer here in the outside edge of the ovary, that new eggs are being produced. Because that would make sense, because at least that's the same location that sperm cells are produced in the seminiferous tubules. If that's the case, then we're not dealing with eggs that are as old as the female. So, because there are lots of women that get pregnant at 40, and the concern is a 40-year-old egg is going to cause a greater risk of having some sort of birth defect, like Down syndrome or something like that, or autism or whatever. But I don't know, and I'm just speaking off the top of my head, I don't know if the numbers of cases of Down syndrome correspond, have a higher frequency of occurrence in older women than in younger women. So I don't know that. But because if females are continuing to make new eggs, the egg would be as healthy as one from an 18-year-old. So anyway, the point is that all these eggs, each month, a cluster of eggs are brought to maturity. One egg is selected, and that's the one that is ovulated, is released. That's what's happening right here. There is the ovulation taking place, and there's another egg coming along that'll be ready to go in 28 days, in the following month. 28 days later, you'll have another ovulation and another ovulation and another ovulation. The scar that occurs after ovulation, after it heals up, is called the corpus luteum. The corpus luteum has a very important role to play. The ovary is producing estrogen. The corpus luteum is producing progesterone. And progesterone's role is to keep the uterine lining intact. The egg, once it gets fertilized, has 7 days to get down, takes 7 days to get to the uterus. And if it gets to the uterus by day 21, it's got to get implanted. Now, the uterine cycle and the ovarian cycle are only 28 days. Somewhere around the 27th day, the uterine lining gets ready to drop out and start sliding out. So timing is everything here. Now, if conception is successful and implantation is successful, then the uterus will start producing a hormone that will tell the corpus luteum to continue to produce progesterone. Corpus luteum starts producing progesterone as soon as it becomes functional. It'll do that for at least 7 or 8 days. If implantation is successful, then the uterus will produce a hormone called HCG. HCG is what shows up in the pregnancy test kits. You know, the early pregnancy test kits. It's detected in the urine. If HCG is being made, it tells the corpus luteum, keep making progesterone, because progesterone is what's keeping the lining in place. Without progesterone, that line, if progesterone levels drop, that lining will start sliding out by about day 27, and by day 28, it's over, and then we start a new cycle. So we depend on the presence of that progesterone. So certainly the corpus luteum's role is to keep keeps the uterine lining in place. Now, if there is successful implantation, then the corpus luteum will produce progesterone for about 3 months. By that time, the placenta has formed and will make its own progesterone. So, very important role then of the corpus luteum right there. Okay, there's we refer to this as the secondary oocyte. This is the egg is in the middle here, and this is what's going to get ovulated. We call the whole thing a Graafian follicle. There's the secondary oocyte right there. There's the nucleus of the egg. Now these two layers here, the zona pellucida and the corona radiata. The zona pellucida in particular is the lining of the egg that we have to get through for the sperm cells. Sperm cells, it takes thousands of sperm cells to digest away the layers to get to the cell membrane of the egg. We don't get through if the sperm cell doesn't get through the into the cell membrane, nothing happens. And now this is where we see, now this is what the ovary looks like up close. All these cells here on the outside edge are immature eggs that will gradually mature as they get exposed to follicle stimulating hormone. Now, most of these are never going to go anywhere, because remember, you're only going to have 500 eggs or so ovulated over the course of the female's reproductive lifetime. Now, we may have 4,000 or 5,000 eggs brought ready to be released, but only one gets released each month. Okay. And these are all immature cells here that may or may not reach maturity. Okay. There's the corpus luteum. It only lasts for, at best, it will last for 3 months, but typically it lasts about 7 days. It secretes progesterone. Progesterone keeps the uterine lining intact. Okay. Here we see an ovary with a very, recently formed corpus luteum. I've often looked at this. I've often wondered why that ovary was removed. It looks perfectly fine. So, but what do I know? So, okay. Now this is a cross section of the uterus showing it has 3 layers. It has an outer layer called the perimetrium. It has a middle layer called the myometrium. There's the perimetrium, the myometrium, and the endometrium. The endometrial layer is where implantation takes place. Now, the endometrium has 2 parts to it. It has a stratum functionalis and a stratum basalis. The stratum functionalis is the layer next to the lumen. That's the layer that slides off every month when the female is menstruating. The stratum basalis is the layer that stays there, and the functional layer grows back from that every month. I will say that when we count time on the ovarian cycle and the uterine cycle, whatever day that ovulation takes place becomes day 14. Because from ovulation to the start of the new cycle is exactly 14 days. So whether the female ovulates on day 10 or day 12 or day 15, that's now day 14. And it's 14 days until the cycle ends and starts over again. Okay. The vagina is stratified squamous epithelial cells that are filled with lots of goblet cells for mucus production. We have layers of smooth muscle underneath that. There's a smooth muscle layer. Now the breast, this is a female breast. It is a globular structure designed to produce milk. The milk glands are arrayed in ducts like spokes of a wheel that go all the way around. And if you look very carefully, all these little white structures here are the ducts coming up through the nipple. Those at the nipple. The darker area around the nipple is called the areola, but these little white structures here are all the ducts. Yes, there we go. They are the lactiferous ducts. These are the glands themselves, where these are called the alveoli, where milk production is taking place. The epithelial cells secrete milk and stored in there. And when the baby is nursing and sucks on the nipple, it causes the release of oxytocin, which causes milk to get released. The more the baby sucks, the more milk they get. And because they're releasing more oxytocin as they go along. Yeah. Different types of breast cancer. We'll go into this in greater detail. The breast, of course, is, I don't want to say prone to breast cancer, but as a very common cancer. It's probably like the #2 cancer in females. There are a variety of cancers. We have lobular breast cancer, mucinous breast cancer, inflammatory breast cancer, very, very rare, mixed tumor breast cancer, and the most common type is ductal breast cancer, where the tumor grows in the lactiferous ducts, of all the ducts in there. So the inflammatory breast cancer, very unusual. Most of these are pretty unusual. The most common type is the ductal breast cancer. One thing we find very unusual is that 50% of all breast cancers occur in the upper outside quadrant of the breast, the region closest to the axillary lymph nodes. The question is why, and we don't know. Okay. Here we see a lactiferous duct there, a normal duct. There is a duct with cancer cells growing inside of it. And this is what we refer to as invasive breast cancer, where the cancer cells have started to metastasize and spread out. Oh, let me get back to that. Yeah, and this is what it looks like. This is a duct, and this is a cancer cell. Cancer is growing inside the duct. Now, the good news, bad news is that yes, it's cancer and it does spread, but in many cases, it's a slow grower. But there's no guarantees. Sometimes they can grow so fast where there's a mass 1 month, there's no mass 1 month, the next month there's mass. So other times you have this funny little lump there that doesn't change, and it's been there for a year, and then you discover that, oh, well, you can take it out with a lumpectomy. It just depends. Have you checked that out yet? This is a breast model made of silicone, and embedded in there are a series of BBs to represent the size of a typical lump in there. And you palpate it, like you would palpate, your breast for a self-examination in a circular pattern, and you should be able to feel at least one of them in there. So. Okay, so your diagnostic skills are sort of iffy, but they'll get better. Try and do it in a circular pattern, with your fingertips. Yeah. Go all the way around. They're there, trust me. You sort of have to rotate your fingers around it like this. Like maybe you're spreading pizza dough or something like that, You ever spread pizza dough? Mm-hmm. Okay, then sort of that type of approach. Did you feel it?
No. Okay, see, I'm not feeling it.
Okay. I didn't say anything. I'm just telling you what I know. Okay. See, now she got it. Okay. They're just doing that to annoy you, right? Mm-hmm. So, okay.
The only one I'm feeling is.
Yeah, one of them is easy to find. The other two are challenging. Now, I don't have any kind of a scrotal model for testicular cancer, but it's been described to me as feeling like a small marble in the testes. So, and they definitely are real slow growers. Lots of people have testicular cancer and do very well. So, okay. Structures. Here we see the overall reproductive system in the female. Sperm cells migrate through here. The mortality rate drops off. There's no guarantee which way they're going to go. Some may go towards the sperm, some may go away. That has to contribute a lot to their mortality rate. But, theoretically, they're supposed to pick up some chemical trail to follow their way to the egg. Okay. Ovary, ovulation site, fimbriae, secondary oocyte. In this case, it looks like it's being fertilized. Uterine tube, uterus, the cervix, vagina, and really big sperm cells. Okay. One of the things that happens in the vagina, besides the fact that it has all these folds in there and it's hot and it's acidic, is that here right at the cervix, there's a structure called the fornix, and sperm cells go up on either side of this and get stuck. There's also no guarantee that there's going to not be a mucus plug in place here. Usually the mucus plug thins out right around the time of ovulation in anticipation of intercourse, but there's no guarantees. There's the cervix. The cervix's role is to protect the uterus from the outside, at least as far as dust and dirt and pathogens and stuff like that. So normally there'd be a plug of mucus right in there. There's the fornix, these folds on the outside. And many sperm go up in there and get stuck. They can't get out. Okay. The ovary, the oviduct, immature follicle cells, the ovulation site, that would become a new corpus luteum. There are the fimbriae. The infundibulum in this area up here is referred to as the ampulla. That's where fertilization is going to take place. And there's a secondary oocyte being fertilized. Now this shows you the 3 layers of the uterus: the parametrium, the myometrium, and the endometrium. There's the endometrium, the smooth muscle myometrium, and then of course the parametrium there. And this one I like because it shows you the mucus plug in the cervix. Fundus, body, isthmus. Parts of the uterus, fundus, the body, and the isthmus. Again, it's shaped like an inverted pear, about the size of a pear. And there's the cervix and the vagina. There's an implanted fertilized egg. Probably at day 21, there's probably about 150 cells. Okay. Called the blastocyst. Don't worry about that. We'll talk about that in the lecture. And there's the cervix, the plug. And it's designed, it's not designed to protect against sperm penetration. It's designed to keep dust and dirt and pathogens out. Because remember, the uterus is open to the outside by way of the vagina, and that means that the entire abdominal cavity is open to the outside because there is no plug on the fimbriae. So anything that could migrate up through the vagina into the uterus could ultimately end up in the abdominal cavity. Yeah. There's the cervix again, and the fornix, and the vagina. And that is everything we're looking at as far as structure-wise for repro. So any questions? Are you sure? Okay. I tried not to look at you and I said, are there any questions? Okay, so I'm going to get us out of here. I'll have all this posted for you later on today, and I'll see you later in the week.
And it's next week. I don't have class.
Right, next Monday is Labor Day, so we will not be having class on Monday.